If your heart rhythm goes haywire right now, the first thing a doctor might tell you to do isn't actually to take a pill. They might tell you to bear down like you're using the bathroom.
Right, yeah. It sounds completely bizarre, I know.
It really does. But today on the deep dive, we are decoding your heart's electrical panel. We have this really dense cardiology study guide in front of us, and our mission is to figure out, how the wiring goes rogue.
And how doctors spot those patterns, plus the wild acute fixes they use to literally save lives.
Yeah. And you don't need a medical degree to understand this stuff. Just think of the heart as a house with, like, plumbing and electricity.
Yeah,
Today, we are strictly looking at the wiring.
exactly. You just need to know how to spot a short circuit.
So looking at this guide, the top chambers, the atria, they seem to short circuit in three main ways. There's atrial fibrillation, atrial flutter, and something called MNAT.
Yeah, let's start with atrial flutter. The guide describes it as having a regular sawtooth baseline on an EKG, usually hitting about 150 beats per minute.
Which is the rule of 150, right? But, like, what does that actually mean for the patient?
Well, imagine a skipping record. It's messed up, obviously, but it has a highly predictable, repetitive rhythm to its mess up. The electrical signal is just caught in this neat, repeating loop in the upper chamber.
Okay, a skipping record. But then there's atrial fibrillation, or AFib. The guide calls this irregular with absolutely no P waves.
Right.
And honestly, before we even get to the P waves, the rhythm itself sounds less like a skipping record and more like, I don't know, a drum set falling down the stairs.
That is actually a really perfect way to put it. Those missing P waves are the key to all that chaos. I mean, a normal heartbeat starts with a P wave.
Like a single, clear electrical spark.
Exactly, a spark that tells the top chambers to squeeze. But in AFib, that single spark just shatters into hundreds of tiny, chaotic impulses. The top chambers aren't squeezing at all, they're just quivering.
Wow. Okay, so AFib and flutter are intrinsic wiring problems.
Sure.
But what happens when the heart's wiring is fine, but another failing organ decides to hijack the electrical panel?
Yeah, so that brings us to MAT, or multifocal atrial tachycardia. The rhythm is chaotic, but on an EKG, you actually see a flat line between beeps.
An isoelectric baseline.
Right. And you see three or more distinct, weirdly shaped P waves. The hijacker here is usually the lungs. MAT is heavily linked to severe lung diseases, like COPD.
Wait, why would the lungs mess with the heart's electricity, though?
Well, severe lung disease creates massive pressure in the chest. That pressure backs up and physically stretches out the right upper chamber of the heart.
Oh, wow.
Yeah, and that stretching irritates the tissue, which creates new, rogue electrical sparks from multiple locations.
So you can't just shock the heart back to normal then, right? Because the stretched tissue will just instantly short circuit again.
Exactly. You have to fix the lungs first to relieve that pressure. Treat the source.
Treat the source. That makes total sense.
Yeah.
But let's say the source is the heart, and we have an acute emergency, like PSVT. The guide calls this a narrow complex tachycardia.
Basically a sudden, super fast heartbeat.
Right. And this brings me back to my very first question. Why on earth is the first step to bear down? The guide calls it a vagal maneuver.
Well, the vagus nerve acts as the body's natural brake pedal for the heart. So bearing down physically stimulates that nerve, sending a massive slowdown signal to the AV node.
And the AV node is like the toll booth between the heart's upper and lower chambers.
You got it.
But I mean, what if the toll booth ignores the brake pedal?
Then we escalate to a rapid wispy push of a drug called adenosine. It temporarily slams the toll booth completely shut.
Wait, really? Just stops the heart?
Just for a few seconds. It stops the electrical signal to let the whole system reboot.
Okay, rebooting is one thing, but ventricular fibrillation, VFib, that sounds like a total system crash in the lower chambers. I assume we aren't relying on, breathing exercises there.
Oh, absolutely not. VFib is totally lethal. The lower chambers are just quivering, meaning zero blood is pumping to the brain.
So immediate defibrillation.
Yes, a massive shock to force a global reset. That and high-quality CPR rule all here. Drugs like epinephrine are strictly secondary support.
Right. The guide also mentions torsades de pointe. It translates to twisting of the points, and it's tied to prolonged QT intervals, meaning it takes too long for the system to recharge, and a drop in electrolytes.
Yeah, and the definitive fix for that specific delayed recharge problem is surprisingly simple. It's IV magnesium sulfate.
Magnesium.
Yeah, it physically stabilizes the cardiac cell membranes. It basically soothes the rogue electricity and shortens that recharge time.
So we reset the electrical panel. But the guide shifts gears completely here. The long-term danger of these arrhythmias, like AFib, isn't just the weird rhythm.
No, it's the stagnant blood. The quivering chambers allow blood to pool and form clots, which can travel to the brain and cause a massive stroke.
Right, and doctors use clinical calculators to manage this. The CHA to DS2 VAC score tallies stroke risk, like just turning 75 automatically gets you 2 points.
And they have to weigh that against a half BLD score, which calculates the risk of severe bleeding if you put a patient on blood thinners.
Okay, wait. So if someone has a high stroke risk, but also a really high bleeding risk, how is that even a viable treatment plan? You're basically asking a doctor to choose whether their patient dies from a stroke or like a severe internal hemorrhage. That logic seems so flawed.
I mean, it is an incredible clinical tightrope walk, which is why the specific type of blood thinner is so crucial here. Most patients use DOACs, or direct oral anticoagulants, like dabigatran.
He is more targeted.
Exactly. Dabigatran surgically blocks just one specific blood clotting protein, factor TACA. So it's a precise tool with a much lower risk of catastrophic bleeding compared to older drugs.
But there's a huge exception in the guide, valvular AFib. So if a patient has mechanical heart valves or mitral stenosis, they absolutely must use an older, harsher drug called warfarin. DOACs are totally banned. Why is that?
Because mechanical valves and severe narrowing create intense, violent blood turbulence. DOACs just simply aren't strong enough to handle clots formed in that kind of high-pressure churn.
So they need the harsher drug.
Yeah, warfarin is a blunt instrument. It acts on multiple clotting factors all at once. It's dangerous, but it's literally the only thing robust enough to stop a stroke in those very specific structural conditions.
Wow. So the plumbing actually dictates how we manage the electricity. Recognizing a sawtooth EKG leads to one fix, while spotting a mechanical valve dictates another.
It all comes down to accurately decoding those signals, yeah.
Well, here's a final provocative thought to leave you with. We talked about how finding that flat isoelectric baseline on an EKG helps diagnose these hidden misfires. Today, millions of people wear consumer smartwatches that constantly monitor these microelectrical patterns.
Oh, definitely. The data is everywhere now.
Right. So as healthy people start getting bombarded with alerts about silent, asymptomatic arrhythmias, how will that change the way we medicate the general public? I mean, if the house feels perfectly fine, but an app tells you the wiring is weird, do you tear down the walls?